Welcome, everybody, to today's presentation, Support Beyond Care. I am excited to be able to be here with you today and present along with my good friend and an esteemed physician, Dr. Todd Hockman. Thank you for hanging out with me today.
Thank you for having me, Michael.
This is an exciting opportunity for us because it's the convergence of two worlds that don't come together often enough to share a perspective, the medical world and the legal world. I, of course, am disability attorney Michael Leiner. Dr. Hockman has treated patients I'll let him introduce himself a little bit more and talk about his practice. But ultimately, the goal of today is to educate you a little bit about Social Security disability, and also to explain how um, doctors can work more closely with people going through the disability process, including but not limited to the attorneys who are helping people going through the process. So, Dr. Hockman, before we get into the content of the presentation, do you just want to introduce yourself a little bit?
Sure. My name is Dr. Todd Hockman. I did my undergraduate at Tulane University in New Orleans, Louisiana, where I graduated with a Bachelor of Science and a major in cellular molecular biology. I then went on to Medical College of Ohio or the University of Toledo College of Medicine, where I received my medical degree, followed by a internship and residency in both internal medicine and pediatrics, and I've been out practicing now for over 20 years.
20 years is a long time to be practicing, Dr. Hockman, with such a youthful face. um, so yeah, we're excited to come together. We're also planning to collaborate on some other projects that we'll talk about towards the end. But let's get into the meat of this presentation here today. And I'm just going to start by talking a little bit about SSD and SSI and explain what is the difference between these two benefits, which are so crucial to my clients. There's two types of disability benefits that are offered by the Social Security Administration: um, Social Security disability insurance and supplemental security income. But very often people don't understand what the differences are between those two programs, what the requirements are for them. And so I want to talk about that at a baseline. What I think is really important for people to understand is that both benefits require somebody to be unable to work at a level of what Social Security calls substantial gainful activity. It's an amount of money. This year in 2025, it's $1,620 per month. It's going up next year in 2026, for those who may be watching us in a few months, to $1,690 per month. So doesn't mean you can't work at all. It means you can't work above a certain threshold. And who have so you have to be unable to earn more than that amount of money because of a medically determinable impairment, which can be physical or mental. It's not one or the other. And you have to be unable to work for a period lasting 12 months or more. That's called the durational requirement. But to go a little bit deeper into the differences between the benefits, SSD benefits are based on your work history. Generally speaking, when somebody is working and contributing to Social Security through your FICA taxes, what you're buying are insurance credits. It's like paying your car insurance premium every month. While you are paying, while you're paying your car insurance premium, in case you get in an accident, you get covered. Similarly, while you're working and paying Social Security taxes through your work, if you eventually become unable to work, Social Security offers a program that allows you to receive some income when you can't work anymore. Generally speaking, you have to have worked and paid into Social Security for 5 of the 10 years immediately prior to becoming disabled in order to qualify. And what's nice about Social Security is that it comes with some additional things as well. Instead of just benefits for the individual worker, one, it comes with Medicare. So after you've been in receiving Social Security disability benefits for 24 months, 2 years, you actually are eligible to receive Medicare benefits as well. Social Security disability also provides dependent benefits. So if you have children who are under the age of 18 or 19 if they're still in high school, but until high school graduation, they can actually receive benefits on your work record as well to account for the cost of managing a household. Um, SSI benefits, on the other hand, there's a big distinguishing factor is that they are not based at all on an individual's work history. Instead of being based on your work history, it's based on financial need. It's essentially a federal poverty benefit for people who are disabled. You don't have to have worked a single day in your entire life in order to receive SSI benefits. Instead, you have to fall below the government's federal poverty guidelines. Generally speaking, what those are is somebody can't have more than $2,000 if they're a single individual. Cash, stock, bonds, anything that's easily convertible to cash. You can't have more than $2,000 in assets for a single individual, or $3,000 if you're married. Now, there's some exclusions, though, that I want to quickly cover. There's others, but I want to talk about the two main ones. Um, Social Security does not look at the value of your home if you own it and live in it. If you own it and live in it, that's not counted towards the $2,000 or $3,000 resource limit, or the value of one car for a single individual or two cars for a married couple if those vehicles are used for medical transportation, which is basically uh, any vehicle that you might have. But extra vehicles beyond one for a single person or two for a married couple are a countable asset and actually can keep somebody from being eligible to receive SSI benefits. So there's some interesting distinctions between the two benefits. SSI benefits do not offer extra money for dependent children. Okay. Um, and also, instead of coming with Medicare, which is the health insurance offered by the federal government, um, SSI benefits come with Medicaid, which is funded largely by the federal government, but it's administered by the respective state that the recipient lived in. Um, there's a lot of different criteria for disability benefits. The things that we're looking for to, help somebody be approved for disability benefits. Certainly, I talked about the durational requirement. It's important that you have an impairment that's going to last or be expected to last 12 months or more, or is expected to result in death. Age is a big factor in a disability case as well. It gets a little bit easier to receive Social Security disability or SSI benefits as you age. When you reach the age of 50, Social Security's rules change a little bit. And what's so important during this process is that you have functional limitations which would keep people from being able to work. So we're looking to help people who are receiving adequate treatment, they're following up. If they have, a history of hospitalizations or additional medical visits that they need, that if you're a medical provider, if you have a client, if you have a patient who's older, especially, but you notice that they have not just any functional limitations, but limitations that would keep the person from being able to focus and concentrate throughout an 8-hour workday, use their hands or arms in order to perform, the basic demands of work, even if you are working with people instead of things. If you have a patient who would be unable to sit, stand, or walk for a combined total of 8 hours, whatever it is, those are triggers for when you might want to start speaking to a patient of yours about disability. Um, I want to get some involvement from Dr. Hockman here. Um, uh, just to ask you kind of loosely, as a physician, what's your experience been with identifying people who might be eligible for these benefits over the years?
There is a couple different things. First of all, as the treating physician, you obviously have a better understanding of what their medical needs are, what their medical problems are, what their functional capabilities are, things that may not show up in the medical records. You have a better idea. You're obviously looking at their line of work. You're looking at the scope of their injuries. For example, I have a laborer who's now 61, 62 years old, two bad shoulders, a bad hand, and is in the process of, trying to go through a shoulder surgery. And he's someone that I'm strongly encouraging to look into this benefit because of his age and his medical conditions. So I think you just need to look at your patients and understand them and understand their capabilities in long term. But I'm gonna digress because there's something that you brought up that I think is somewhat confusing for the practitioner when we're making these statements, and probably causes us to be somewhat deterred in completing the paperwork and working with the attorneys. And the terms you just used are somewhat contradictory in our mind. Okay, we're talking
Tell me
about
what those are. I love this.
we're talking about disability. Okay, so now I'm just going to talk from my own personal perspective. I dealt with all different types of disability. We've dealt with individuals who get Social Security disability, there's workers' compensation disability, there's long-term disability, there's short-term disability, obviously. So one of the big differences in the Social Security disability that I'm not sure that physicians completely understand is the ability to continue to work, right? We're trying to get physician statements that quantify and qualify disability for an individual, and yet that individual can still be out there working. So I think for physicians, a better understanding of what the actual criteria are and what we're speaking to and what we're completing forms for certainly helps, because I mean, you're giving us a number of, I think it was $1,620 a month, I believe it was. I guess, obviously that becomes a very subjective number as to what the hourly pay is and how many hours they're working. So what I'm reading at as a physician with no understanding, stepping back and pretending I have no understanding of the disability system is, okay, what are the questions for me that I need to answer on behalf of my patient in their best interest that lets the administration understand that this individual is unable to perform sustained remuneration of employment, but still has the capabilities to go out and work. I think physicians better understanding how those two connect may help.
I love how you bring up that SGA and the subjectivity of the amount of money, because it's something that gets misinterpreted or misunderstood so often, where you're right, because you can earn, if you are a Wall Street banker, you might be able to earn, you know, more than $1,600 in a single hour per month. If you're working as a cashier at your local grocery store for minimum wage, that could be 30 hours a week. But what's really interesting is, and from a perspective, I see how that can be so confusing to a doctor who's trying to make sense of these rules. It doesn't matter. All Social Security looks at is the amount of money. So even though the banker might earn more than that amount in 1 hour a month, and the person who works at the grocery store might earn less than that in 30 hours per week. The person who can work 1 hour per month is not disabled, and the person who's working 30 hours a week could be disabled. And that's very confusing.
And I think even more confusing for my profession, Michael, is the understanding of certifying disability when an individual is still capable and going out and doing some work, and where that line is drawn. I think if my physician and my colleagues had a better understanding of we are certifying disability in this individual and what that means, and what they're still capable of doing, I think that would open up their eyes as to saying, oh, well, we're not saying this person is completely disabled, cannot do anything at any particular point in time, but they have some capability, but just unable to sustain it.
I think that the message that I would want to give to my doctor friends is focus less on the amount of money and I think you just said the key word right there. Do you have a patient who you don't believe could sustain work over a 40-hour work week? When SGA comes in a case is more when somebody is working and earning more than that, then it is a predictive factor of, well, you're in the banking industry and in 2 hours a month you could earn that. So, Social Security is considering whether somebody could work full time. They're not considering, could you earn enough money in your profession to get over that threshold? The question is, could somebody maintain work 8 hours a day, 5 days a week? So, from the medical perspective, if you're trying to decide whether you should recommend disability for one of your patients, really that question should be like you framed it. Could this person hold the job full time? If the answer is no, it's not a bad idea to bring up to them, the idea of looking into Social Security.
So
Um,
I'm sorry to interrupt. The
no,
difference
please.
here is, and I want to make sure that we are clear as a physician, as a profession, and as patient advocates. It's my understanding that long-term disability, or most long-term disability policies, is the patient is incapable of performing their profession sustained over time. Versus Social Security, we are looking at the individual is unable to sustain any employment over time, but still maintains the capability of doing some work with a maximum of bringing in $1,620 per month. Is that a fair statement?
Very fair statement.
Okay.
Great way of summarizing it. Yeah. Um, and, one thing that I think is especially important for the medical and larger community to understand is just how challenging it is to receive these benefits, which is really the purpose here on this slide. This is not a quick application review, check comes in the mail shortly after process. Um, Before you send a patient down the path of applying for disability, I do think it's critical to understand that this is a system of denials and appeals. Um, 2/3 of people who apply for Social Security disability benefits get denied at first when they apply. Um, a mistake that gets made very frequently is when somebody gets denied and their first response is to either reapply or give up. Understand that there's an appeals process that you can be very successful with if you see it through, and that's kind of where we go from here. If you get denied, if you have a patient who tells you that they were denied disability, if you believe that they're disabled, I would tell them to consider filing an appeal. Okay. The first appeal that gets filed is called reconsideration. That's where Social Security takes another look at the application and decides whether or not they have whether or not they believe that the person satisfies the requirements. It's almost a rubber stamp denial. 90% of reconsideration reviews are denials.
So
So then
go ahead,
jump
finish.
in.
I don't want to
No,
interrupt.
please. No, I want to hear your question.
One of my questions for you, and this is I'm going to bring up some of that comes to my mind, who I believe was denied initially. So first of all, yes, I think as far as the physicians go, when we see the writing on the wall that these individuals may require disability down the road, I think as a patient advocate, we need to push this process. I don't think many people, and whether they're physicians, patients, understand when exactly is the right time to apply and how long this should take. So I think as a physician advocate, you really want to be looking for the signs, maybe not where we are now, but where this will likely be in 6 months, 9 months, 12 months. Even individuals that are going through surgery, 60-year-old laborers that are going through surgery, I want to open the practitioner's eyes to the opportunity to getting the individuals to apply for disability at that time, with the understanding that it may be denied and may be a long time process. And look, best case scenario is they get granted disability, but they're able to go back to work, and they don't pursue it. But I think preparation, and I guess that was my one question for you when we look at denial rates and we talk about these ages. Obviously, in a 35-year-old is going to be a little bit more complex. But in an individual 50 to 65, as you framed in the previous slide, when's the right time to tell them to apply? So I have a laborer who's going to have hand surgery, and is about to get the hand surgery, let's say in October, because he knows he's going to be laid off, and he has the hand surgery. Is he waiting till he's off work? Is he applying while he's working? Obviously, if he's applying over the summer while he's planning to have the surgery in October, he's getting ahead of the game in his mind, right? Trying to get the application process moving. But is that the potential of a denial, which leads to the appeals process and a longer delay, or do they wait until they actually get cut by the knife and then apply with the potential that they can get through the system quicker?
It's a great question because there's so many different how we strategize when we tell people to apply for disability benefits. It's unique for every individual. While that person is continuing to work full time, they can't apply because if you are earning above SGA, then no matter what, you aren't disabled. If you have somebody who comes to you and says, I've had to cut back my hours, I'm working only part time now, that's an indication that it might make sense to speak to them about applying for disability. I think that knowing that 1620 per month rule can help you in saying, well, if you're earning under that, you can apply if you're working part time. But there's other components as well. So for that person who's leading up to a surgery, even though you know that them working might, until they have the surgery, might harm them, knowing that they really can't apply until they stop, I think that having that surgery is probably a triggering event. But then the question is, and I know you weren't a surgeon, right, Dr. Hockman?
No.
But most surgeons think that whatever they're operating on is going to fix a problem. So then it becomes a durational question. Because remember, you have to be unable to work in any capacity for 12 months or more. So depending on what the surgery is, whether it's on a back, a hip, a hand, whatever it is, if you expect that, okay, it's going to be, a surgeon enters a surgery thinking, I'm going to go in, I'm going to perform this total knee replacement. This person's going to need 6 to 8 months of recovery, but then they'll at least be able to go back to doing sedentary work, or maybe they'll be able to stand long enough to do something that approximates what they were doing. Remember, the person has to be unable to work for 12 months or more. So that's a side consideration here. The bottom line is there's so many different balls in the air, and that's why collaboration between our professions is so huge. And that's really what the purpose of this whole webinar is. As a doctor, I wouldn't expect you to necessarily know what all those different balls are. As a lawyer, we can ask the questions and help somebody plan, here's where, with what your impairments are along the trajectory of work that you're on or plan to being, this is where this is what I think makes sense for you. If you're able to keep working right now, stay working until you can't anymore. Once that surgery happens, why don't we turn in an application and see what happens? Because you never know if a surgery is necessarily going to fix something. It might be 6 months until there's actual clarity on whether something was successful or not. Certainly people have a surgery, heal up, it seems like they're improving, and then they regress. That happens all the time. So, but speaking to a lawyer in that circumstance can really help someone.
Well, and the other thing that I want to encourage the individuals that are injured or sick and applying for disability benefits to really keep in mind and remember is, if you're dealing with a surgeon, you're usually dealing with a surgeon for one body part and one problem. And that may be a defining event, right? The shoulder surgery may be the defining event. But I really encourage them to also be working with their primary care physician at the same time and letting their primary care physician understand their concerns about their long-time longevity and ability to sustain employment. Just because somebody gets through a shoulder surgery and rehabs in 6 months doesn't mean that they're not having other medical issues attended to at the same time. And while that defining event is the defining event that enables them to go through the application process, the chances are there are many other things playing in. So I think the patients really need to be cognizant of that, and that while you may have one leading physician treating one primary problem at that time, if there's other issues that need to be addressed and are being addressed, to work close to the primary care physician so that once that shoulder is where it is, and you send a functional capacity, letter of determination to the surgeon, they give you restrictions. That's just part of the picture.
Yeah. Um, and before we move far ahead, I mean, there's a lot of information on these slides, and one thing that I just I don't want people to miss out on here, so they understand the trajectory here. These cases take time. These reviews aren't fast. Um, an average disability case from beginning to end, most cases take an average of about 2 years, 3 years, depending upon where in the country you are. Um, Different states have their own. It's one process, it's one standard, but states and local hearing offices process claims at different paces. So if you're in Maryland or Florida or Wisconsin or a handful of other states, I would tell you that it might take you 3.5 years on average from the time you apply until you get to a hearing with a judge, which is where you have your best chance of being approved, as you can see here. If you're in Ohio, where Dr. Hockman and I are located, you can get from application to hearing in 12, 14 months. That's pretty routine in Northeast Ohio, in the Cleveland area where we live. So really, geography matters a lot here. But that's also, another ball in the air here when you think about the investment of somebody's time and whether or not they're, whether it makes sense for them to apply. People should understand entering this process that this is slow. And there's not much that can be done to speed it up because it's just waiting in line. Um, Go ahead.
No,
You were
I just
asking about
think that,
these things.
you're going to get to it, I think, in a couple slides, but I just, you start to really feel for the injured and sick individuals that are applying for this in need, that are waiting 3 years, even a year, for a disability benefit when they cannot be sustaining employment. It's just extremely frustrating, and I think, physicians really need to advocate on behalf of those patients, to understand the predicament they're in.
It is a truly cruel and complicated system for the people who are going through it. To be unable to work, you don't know how you're eating, get where you're going to be, how you're going to be able to afford your medical treatment, how your housing is going to be paid for. Basic needs are hard to come by during this process. So, um, and Social Security keeps moving the goalpost. It doesn't seem like much is being done to make these cases go quicker. Um, and so it really is a significant adversity that people applying for these benefits face. Um, I want to talk about there's a lot on here that I'm not going to cover because if you're watching this, you can read it. What I really want to focus on, why claims fail. And I want to, because we've got Dr. Hockman here, I want to spend time talking about the medical reasons that cases fail. I know you love talking about medical records, for example, but, um, you know, in my experience as a lawyer, the reason that disability claims don't get approved more so than anything else is there is a gap between what's actually happening with the applicant, the patient, at least as they see it from what they're actually experiencing, and what's expressed inside of the medical records. It's a documentation issue. It's that they feel that they're having a 10 out of 10 pain, daily or near daily, that they have 3 to 4 days per week at least that they can't get out of bed, that they're struggling. But when you look in their medical records, they're not doing a great job of telling that story. And, something that I tell my clients all the time is you don't get Social Security disability benefits because of what's actually wrong with you. You get disability benefits because of what you can prove is wrong with you. So, hearing that, Dr. Hockman, and I do think that this is like the thing that leads to more denials than anything else. I'm a patient. I'm applying for disability benefits. Um, what can I do to improve the quality or outlook for my case, knowing how important medical records are?
Yeah, I mean, that's always tough, and there are many different reasons. But I mean, the first thing I'm going to talk about is the doctor patient relationship is something that goes on over time and is not built on one point in time or one visit. I think it's extremely important for those that are making the decisions to keep in mind what physicians are going through and how much time the physicians are spending with these patients. If you're spending 15 to 20 minutes with a patient that's applying for disability, right? Let's stop for a second, okay? If you're spending 20 minutes with a patient who's 35 years old, healthy, and has a sprained knee, that's a pretty direct visit. But if you're getting 20 minutes with a
Yes.
patient that's coming in and has disability concerns, well, now your chances are you're dealing with a lot of medical issues, right? So you're looking at them, they're coming in, they're complaining about their shoulder, they have their high blood pressure, they have their diabetes, they have their cholesterol, they have their cancer that's in remission. You're asking all these questions about these pertinent issues for them so you can make sure that you're guiding them correctly. You're doing your physical examination. It's not just focused on a shoulder, it's focused on the heart, the lungs, the stomach, everything else. You're interpreting data. You're then coming up with the best treatment plan for each one of those individual issues and doing that in a time frame, which is so I think that when physicians are completing paperwork or being asked to complete paperwork, being asked to focus on disability, it initially feels like you're putting a lot more on their plate and they're just not sure how they're going to fit it in with the time. And plus, there's, again, as we talked about earlier, I mean, just because you're granted Social Security disability doesn't mean you can't work. So there's a lot of confusion. But I think the medical documentation, I think being organized and succinct as a patient is very important, and taking in your priorities. I'm going to tell you that no matter who you are, no matter what profession, when you're busy and you have a focused visit or you have a purpose of a visit, and then there's just all different issues coming in from all different angles, it complicates things, and it complicates it for the physician in understanding the true situation. So I think being very succinct, but I think there are also innate medical problems into the way the world's going. First of all, we're doing a lot, almost everything now in electronic medical records, which is a lot of clicking boxes. So there's a
Yes.
lot more general statements than more focused statements. Same with the physical examination. Again, if you're doing electronic medical records, a lot of checking boxes versus, putting your own statements in. And then you're completing paperwork and doing the diagnosis. So I think that the electronic medical records have taken some of the human nature out of it to explain. I know we've talked about this in certain client patient in the past is the gap between the explanation, and us taking an extra second to really fill in that blank. It's one thing to have a vague statement where they can't sit for long periods of time. But I think taking a minute to explain that, this individual has a herniated disc at the L5S1 level with some facet arthropathy. And yes, he did just get some injections, so his pain levels are under better control. But this is a palliative and not a curative process. When we put him back in the seated position, we're placing more stress on the facet joints and disc. Therefore, we're doing him a disservice, putting more pressure on the lumbar spine, and really explaining why we are recommending that he is not sitting for long periods of time, even though his pain is better with the procedure he just had. So I think a lot of it is really just the explanation of point A to point B, and taking a minute or two to try to put that in the medical record and the narrative.
A tip that I give my clients a lot, too, and I want to get your take on this and whether it's useful, if it is a doctor, is this annoying? Um, and I'll give you some examples, but my clients, I tell them that if they're available to them, use electronic record portals to communicate with your doctor. So you're using electronic medical record things. You're using you're keeping records electronically, but now, like through my chart, Epic, these big hospital systems, which is how so many people are treating now, offer a way for you to message your doctor directly, and your complaints that you're concerned aren't ending up in your medical records can then appear in your records when they're requested. A great example, a couple of them are, for example, like seizures, where it doesn't make sense to go visit your neurologist every time you have a seizure. It doesn't make sense to go visit, to go to the ER every single time you have a seizure. But the frequency of those epileptic events is crucial to whether or not you're likely to be approved for disability with a seizure disorder. And so I tell my clients every single time you have a seizure, you need to go into your electronic medical record and fire a message off to the doctor.
That's
I don't know if
ingenious. That's ingenious. I mean, that honestly is something that everyone should be doing because
are you calling me a genius here today,
I
Dr.
did, I
Hockman?
did, I
I just
did.
want to remind you,
I
you
know.
are
I will.
under
I will.
oath. You are being
We can
recorded
talk
here
about that later.
today.
But anyway, no, I think that is because that's a way for yourself to get points into your medical record that may not be coming across, right? I mean, if you call the front desk, which you're not going to get through the office in this day and age, but if you call the front desk and leave a complaint, then it has to get to the doctor has to document it. But once you put it into these electronic systems, that is staying there forever. And, I do a lot of medical record reviews, whether it's on disability, injury claims, and it's very frequent that I see these communications from the patient to the physician. And I think that is a way to quantify how many seizures you're having, make sure that, everyone knows how you're feeling at every minute and not just that 15 to 20 minutes that you're in to see your doctor that month, 2, 3, whatever it is.
As a physician, does it annoy you when you get messages like say you're my client's neurologist or whoever, and you get all these messages from them saying, just wanted you to know I had a seizure. There's not much that the person can do with that. Every message isn't going to translate to changing treatment around or anything like that. But I'm curious, how do you respond to that as the physician?
It's a good question because you could see where that could be a little bit more than you want to hear every time someone's having a
Right.
seizure. And you can see where that, when your office staff gives you the message and they're on their anti-epileptics and they have their, medicines at home and their rescue medicines at home and they're used to the situation that you'd be like, okay. But I think it's the for me, I always like to know. I always like to hear it. Now, for you, I'll be honest. If I hear something that's called into the office that doesn't need to be documented medically, I don't necessarily make a note every time of it. But I
Sure.
think it's extremely important that it is noted mentally, right? And so if you have a seizure patient that is calling your office more frequently reporting seizures, okay, they may know how to deal with the seizure, but now these seizures are happening more frequently, and you can assess that situation and bring them in to determine what to do with the medications. But I think, yeah, I think it's important to keep your physicians informed of the pertinent information. Okay, I mean, you don't want to be the boy that cried wolf, so to speak. And just keep sending, little things, little things, little things, and all of a sudden there's a major issue and it's not getting the same attention. But I think it is definitely a way for you to communicate and get your. So let me take a step back. When we do a note, right? We do a note. It's called a SOAP note, right? SOAP, subjective, objective assessment plan. It's a little bit different now, but the subjective is what the patient is telling us. And I
Mhm.
think that subjective, it does not need to just come from that 15 to 20 minutes in with the physician, but can be coming from the patient over time through the medical record. And I think that's a good way to make sure that you are heard.
Um, Well, this is a great discussion. I love this so much. I think that we've had this slide up long enough that people have had the opportunity to kind of read some of the other red or yellow flags in disability cases. But of course, we're going to put our contact information up at the end. So if this raises additional questions for anybody, uh, I would love to hear from you. But I don't want to not move forward here, this slide actually kind of plays into the conversation that we just had. Social Security relies on medical records, test results, imaging, labs, physician notes, and medical treatment history as an objective source of the truth. The better your records are, the more that you have, and most importantly, most critically, the more consistent that they are between each other, the better the outcome in the case is going to be. Just looking at this, is there anything else that you would add, or do you think you kind of fleshed out your
I, you
thoughts?
know, I, I, I I guess I'll give a plug for us to deal with this a little bit more. You guys always have the opportunity to seek opinions outside of your regular medical providers too.
Yeah.
Sometimes that does help. So, in individuals that have complex cases, that have a lot of medical problems, that have a lot of records that need to be reviewed, where the orthopedic surgeon may be looking at one issue, the neurologist looking at other. I think getting a compilation of those medical records and the FCs and everything's been done, and getting it to somebody that's a physician that's experienced in looking at these issues and dealing with these issues, that's willing to look at the records, examine you, and help come up with definitive opinions with regard to ability to sustain employment also helps.
Yeah. Great. Um, Again, and these are some things that I think that this brings on a conversation that's even a little more targeted in here than before. A tip that I give my clients, and I think this fits right on here a lot, and I tell this to providers in a different way. So, my clients will, too often, when somebody goes to a medical appointment, their doctor will they'll walk the doctor will walk into the treatment room and they'll say, "How are you doing today?" And the problem is that as a patient, just the fact that you showed up for that appointment, sometimes even if it's virtual, might mean it's a good day for you. Especially my clients who are dealing with severe mental health issues, how often are they canceling their appointments or not showing up because of how they're feeling? I like to tell doctors, instead of walking into a room and asking the patient, "How are you doing today?" say, "How have you been since the last time I saw you?" And even if you're the patient and your doctor says to you, "How are you today?" hear it as though they said to you, "How have you been since the last time you were seen here?" Because it sets a completely different tone for this, which is this vagueness. There's a social aspect to the treatment note, which I think can really harm you if you're applying for disability benefits. When the way it starts saying, "I'm doing well" or "I'm doing okay," and then all of a sudden they're not digging, the doctor is, because you're just being social or not inappropriate with your response, the doctor isn't digging into the fact that you had several days per month where you couldn't get out of bed because of pain, or whatever the issues might be. What's it like for you? What were your strategies? What are your strategies when a client's in your office talking to you to make sure that you're really getting the information out of them that you need to give them care?
That's, I guess, the way I look at them, at my patients, just in general, is exactly what you're saying. I think the first time you meet a patient, you are writing a book, right? But I look at it as if you're writing the Cliff Note version of the book, right? You're trying to get all the pertinent. You're trying to figure out who this patient is. You're trying to figure out what the big issues are, come up with diagnoses and a treatment plan. But as you alluded to, that doesn't stop right there. Then we set up a follow-up appointment. And when you come to that follow-up appointment, we ask again more questions. And I think you're spot on in saying, "How have you been since the last time you were at my office or at the office?" I think that's very important, because that is the story you're telling, right? The next visit is the next chapter in the book. And so you're trying to figure out what has gone on since the last time you saw the patient. I often myself, it will know, I saw the patient 3 months ago, so I am going to pick up in the electronic medical record from my last office visit. And I'm going to look through things that have gone on, tests that have been done, maybe urgent care visits, maybe other visits. As you look through those, you may find things that pop out. Well, you saw the orthopedic surgeon because your shoulder was hurting 2 weeks ago. What's that about? oh yeah, it's not better after the surgery, he's going to do another MRI. Just I think as a physician, you really need to go back to the last time you saw him and focus on all the issues that were there and determine the successes and the responses to the treatment you prescribe, what has not worked, and what the next plan is. And you cannot do that focusing on one day and one point in time.
No. Um, a question that I want to ask you is, what something else that I see very often that I struggle to bridge the gap between is findings on objective imaging studies like an MRI, like an X-ray, which might show severe disc herniations, or if we're talking about an EMG, moderate to severe carpal tunnel syndrome. How do those things translate to functional limitations? Oh, you're smiling, doctor.
Well, I just think that's a whole another area that we could get into and a whole different. I think that becomes a lot more
And we
complex.
are going to get into it. Is this a time to plug our upcoming series of articles and pending book that addresses that question?
Yeah, I'll leave that to you,
But I
Michael.
digress.
I'll leave that to you. But again, yes, and that is filling in the blanks, right? And again, I'm going to talk about somebody with. We'll start with an example of back pain, right? We've already alluded to this. So when you're dealing with the back, most individuals that have any sort of disability of the back understand what a disc herniation is. They probably at this point understand what the facet joints are. They understand the nerves. They understand the pain that goes with these issues when they're active and irritating. Now, from a physician's standpoint, we may give them a restriction that says needs to take a break every 20 to 30 minutes to stretch. You send them off and you move on. But I think what's not being conveyed, which would be helpful for you, is the understanding of the anatomy, right? So somebody has a herniated disc. What is the function of a disc? Simplified, a disc is a balloon filled with jelly that sits in between the bones in your back that acts as a shock absorber to help take pressure off the surrounding structures. As that disc deteriorates with time or herniates and puts pressure on a nerve, now this individual is not only having back pain, but they're having pain shooting down their leg. And it's incapacitating pain. So then we send them over to see a pain management physician. They decide to do an epidural injection, which is a steroid going in. A steroid goes in, a steroid has effect usually 6 months. But again, it's palliative and not curative. So when you take these individuals and you send them right back to the same situation where they're sitting, they're now putting more pressure on their back, and it's more likely that this injection isn't going to last 6 months. The problem was never fixed in the first place. It was just the pain was alleviated. So this pain is never going to come back. So I think just the explanations between what we're seeing in MRI and the restrictions, or what we're seeing clinically, I should say, not just in MRI, and the restrictions are important. I've run into this with dentists, okay, and this has been more of a long-term disability issue, I think, than Social Security. So it's my understanding it's performing their own job task. But I've run into dentists who physically are pretty healthy, with the exception of their bad arthritis in their hands and their carpal tunnel syndrome. That it's very important for a dentist to be able to do fine manipulation with his hands and be able to repetitively bend his wrist to do the work he needs to do in your mouth. So the carpal tunnel, in that situation, while it may not prevent certain people from doing their jobs, it is going to prevent other. And it's the same thing when you're looking at shoulder MRIs, right? Shoulder MRIs can show impingement. What is impingement? Impingement is basically pinching on the muscles by the surrounding bone structures. An individual with impingement shouldn't be doing overhead work, right? They shouldn't be loading their shoulders. There's other activities they shouldn't be doing. So I think taking the time as a physician to explain how the pathology leads to the restriction is very important. And I think doctors can do that fairly freely and fairly easily without necessarily making the statements of disability they may not be comfortable with, and then letting yourself take it from there and utilize the medical records and the patient statements and the objective findings to present the information to the administration.
Yeah. Yeah. This is so helpful, doctor, and I'm just so glad that you're here to explain this. Um, this is more for you here. Do you feel, is there stuff here that you would add?
Um, No, I mean that's exactly right. I mean, when you
Yeah.
walk into your doctor's office, they're looking at your medical problems. They're worried about your treatment. They're worried about their documentation, and they need to meet certain criteria for their billing. They're just not thinking about the disability. It's just not something that's in their mind. They're not intentionally ignoring you as a patient. It's just not what their focus is.
Okay. And this I think was stuff that we've covered. This is interesting to me, and I think that this is where um, I run into this a lot. One thing that we try to do because it's the evidence that Social Security gives the most amount of weight to is get what's called a medical source statement from our client's treating provider. Because those medical records aren't written in terms of, you know, person has severe herniations in their lumbar spine, and so as a result they can only sit for 15 minutes at a time, adding up to an hour of an 8-hour workday, for example, because they're written for care, they're written for in terms of objective findings. Um, doctors often, getting a medical source statement can kind of be a bridge between what I need to prove and what the records actually say. But doctors often have a lot of hesitation to get involved. And I think this covers a lot of the reasons, and I'm going to ask you your thoughts on these. Unfortunately, it's not always easy for our clients to get these forms filled out, which just asks the doctor how their client is functionally limited over the course of an 80-hour work week. I think the biggest one is probably the first one, which is they're afraid of being dragged into litigation, right? Um, and then we're taking a profession that's already, and you and I live in a big medical town, right? Cleveland, Ohio is a huge medical town where um, and because of that, there's a lot of treatment that's coming. It's really, people are treating with a stopwatch on, where you have 6 minutes, 10 minutes, 15 minutes, a half an hour to do an appointment. Not the old school 1950s doctor that I'm sure people went to med school wanting to be, where you got to sit down with your patient, get to know them a little bit, hear about their whole health history, diagnose. It's quick, 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 quick. So when somebody comes in and they have a million forms that they're putting in your face to help them with their Social Security case, it kind of gets cast aside. Are these the types of things that you think explain why it might be hard for us to get medical source statements? What are your observations in the medical profession?
Well, I think you hit it one on the head. I mean, I just was with a family member at an appointment earlier this week, and it was no. What is your one issue we're going to focus on today? And so there are those guidelines out there where you have one appointment, one issue. So you're right. It's not where you can deal with it. Not necessarily can deal with everything at once. And yeah, you really are hitting the nail on the head. Physicians can get stressed and overworked at times, and they walk into a room and they walk into a patient and they know that they're going to follow up on their diabetes and their hemoglobin A1C and their blood pressure and their heart disease, and they know what they have to do for the appointment, the purpose of the appointment. And then there's more forms that come in, and that, it's just not what was planned in the physician's mind. It's going to take time. Again, we talked about there's some confusion. I think one of the things that you can provide is to make sure they understand what what the disability is about, right? In your situation, we're talking
Yes.
about Social Security disability, but in others, it may be long-term disability, maybe workers' compensation, but all those come with their own set of circumstances and rules, and whether it's their own occupation or any occupation or any occupation, but you can still work and make $1,620 a month. I mean, all these things to doctors are just confusing, right? So they look at the paper, throw it aside, and they do what we know to do, and we move on. So I think really an understanding, but then I think honestly it is the moment where you take a deep breath and you get situated in the room of the patient and you realize that these papers aren't going to take you more than 5 minutes to probably fill out, because you know this patient better than anyone else. You've seen them tangentially over time. So you're not just looking at one point, you're looking at points, and it's your medical opinion, and you're allowed to have a medical opinion, and you're allowed to, knowing the patient, say that you are comfortable with them sitting 2 to 3 hours a day with breaks or standing. And you know what? There may be another doctor with another opinion. There may be another physical therapist with another opinion. That's fine. But you're in a position as a patient advocate for your patient to take the time to give your best interpretation of their physical capabilities. That's all you're asking them to do. I've seen the forms many times. And then beyond that, the statements of disability are going to be determined by the administration and the way they see the patient client and the way you do your job and all the other factors that fall into place. So I think for us as a physician, we need to take a deep breath, realize that all we're doing is giving our opinions based on our knowledge of the patient to the best of our ability. And that is going to be one piece of a puzzle that is going to be put together in front of administration to help determine whether or not the individual is able to get the disability.
Yeah. You know, there's so many different things that we do as an office to try and support patients. And things that I think that doctors can do, like we've been talking about this whole time, communicating that Social Security is an option for you when the signs are there, when it seems to you as though you have a patient who might not be able to sustain work. And what we try to do is take as much of the burden off of the doctor as possible. That's why I was in saying earlier, um, you know, you can have this information. I like to, give my friends who are doctors or people that I'm working with information so that they can at least talk the talk a little bit. But at the end of the day, just sitting down, explaining different outcomes, different possibilities takes a big weight off of the shoulders of the doctor when somebody comes to you and says, "Hey, do you think I should apply for disability benefits?" This is what we do. Let us be the experts in advising your patients as to whether or not we think that they have a strong likelihood of being approved. We want to do everything that we can to support doctors who are helping our clients. We try and reduce the number of record requests that we make, reduce redundancies. We've tried to create, when we do ask for an opinion from a doctor, create forms that are streamlined, easy to answer, but helpful, so that if you're going to take the time to fill out a form to help a client or one of your patients, it's going to be worth that time, because your responses are going to be easily defensible and used to support a winning disability claim. So working together, I think there's just so many opportunities
I, I,
for
you know,
collaboration.
on your end, just a thought. I've seen the forms that are sent out for Social Security, and we're talking about simplifying things, which is essentially what the electronic medical record has done as well. And we talked about how the electronic medical record often leaves room for interpretation, or is not as detailed as you want. I think it's very important that when you come up with these concise forms, that they definitely contain all the information you need. And just something you may want to consider and look at is, keep an eye on the electronic medical record with the forms you're sending out, and paying attention to where those gaps may be, so that listen, making it streamlined and easy is also getting you the questions that you want, that you think you see in the medical records, but you're not necessarily certain.
Yeah. Um, there's several things out there that I want to make sure that people watching this are aware of. There's, the forms that we've been talking about here. They're all available on our website. And linerlegal.com. We're going to put out this presentation in a clickable format so that people watching this can click right on the screen and access that link and see all the different forms that you can use to potentially support your claim. I talked about how we want to give people quick and good information about whether they have a case. So we've this website, linerlegalsurvey.com. It's a quick resource that you can go to or send one of your patients to answer a few basic questions that'll tell them whether or not they have the potential to at least file a disability claim. And so I want to make sure that people have this good information. What I want to talk about here at the end, I want to make sure that I'm actually gonna I'll leave each of our individual slides up here for a minute so people can see our information. But you and I are working on a few exciting things together. So it's not just this presentation here today, which I know will live on in the internet for a long time and people can access as a resource. There's been such great discussion, but we are working together to create a basically for the legal community a um, first we're going to write a book together which helps link these worlds, puts into terms that lawyers can understand or helps lawyers understand what they should be looking for in their clients' medical records to help them prove that they can't work full time. But ultimately, this extends beyond Social Security disability lawyers, which I am, into the world of workers' comp lawyers, PI lawyers, med mal attorneys who need to understand the human anatomy and how it works in order to help prove that your client has permanent damage or what might be wrong. We read medical records, but we don't really know what it means. So, what we're going to try and do is create, I'm thinking of it as a medical school for attorneys that they can attend, that will teach them how things work, what they should be looking for, and helps you. It's basically like you get to retake your high school anatomy class, except you get to do it with a doctor teaching you and in terms that'll help you do your job better. So this is something that you and I are spending a lot of time working on. We're working on some articles that help bridge gaps for Social Security lawyers in particular, and I'm just really excited to continue great work with you, Dr. Hockman, and I know that you and I can really help a lot of people together.
Thank you, Mike. I'm just going to say one other thing, if I may. First of all, if there anyone has any thoughts about any material they want to see in the future, please let us know what the most pressing issues are, and a little just information. As you saw, my information, I'm available to help any of you at any time. You can feel free to reach out by email or phone. I'm happy to review the medical records, give opinions, write reports, do whatever you need to help you in your journey.
That's great. That's great. I'm so excited for your contributions here and going forward, Dr. Hockman. And thank you, everybody, those of you who made it through this hour long presentation, for hanging around with us.
Thank you, Michael.
Bye, everyone.